So Karina, do you want to talk to us a little bit about some of the different CAR Ts that are out there that were presented at the meeting?
Yeah, so this wasn't ASH where we had 7, I think, CAR T talks in 2 different sessions. But there was a interesting poster out of China from Nanjing, and this is actually humanized BCMA. And so I guess they were looking at 9 patients that got a fully humanized BCMA lentivirus transduced CAR T, and it was 4-1BB co-stim. And 100% response rate. And I think the interesting thing was 3 of the patients actually had talking about can you treat BCMA again, 3 of the patients had a CAR T that was mirroring SCFV BCMA that had relapsed on there. And 2 of the patients on this trial ended up with CRs and ongoing CRs, and 1 of the patients has a VGPR still. So I think that question of can you treat the vehicle, the target's BCMA, but what you're putting with it matters. And there's some anecdotal cases of patients that got the ADC or got a BiTE, then went on to a CAR T trial, and they actually responded when they didn't respond initially, right? So I think, yes, the BCMA world is saturated, but we don't know enough about the actual antigen, right? And I don't think you can compare it to CD19 and say, well, Blina does this, and then the CAR T doesn't work as well. I don't know you can say that about BCMA. So I think we do have a lot to learn. I agree that there need to be a lot of other targets. So most of the trials have been with BCMA. Of course, the New England Journal paper that recently came out on BB2121, 11.8, progression-free survival, 11.8 months. If you're MRD negative, 17.7 months. No other therapy, which is huge compared to continuous, needing continuous infusions or therapy. I think that was the biggest thing for our patients to have 12 to 17.7 or even more months where you have no other therapy was quality of life, once again, was pretty impressive. And I think the other trials, Legend and Janssen, their data looks pretty good. A little bit better PFS, like 22, 23 months, but these patients had a little bit less in terms of therapy, they're about 3-4 lines. Same thing with this trial in China. It was about 4 lines, prior lines of therapy compared to BB2121, where there's 7 to 8 prior lines, so more heavily treated. So looking at that data, I think all the CAR Ts have pretty impressive data in that sense. And of course, there's JCAR and Poseida. There's so many that we're all looking at. But allo, I mean, that's the other next thing. And we do have a trial opening up with CS1, allo CAR T, where both the CS1 and the TCR are knocked out. They'll hopefully be open in the next couple of weeks, and we're really excited to see what happens because now you have normal donor T cells. They haven't been knocked out. You don't have to wait, a month. You don't have to do bridging. You just go. The problem with allo, the question is persistence, right? Of course, we have to do higher lymphodepletion, so the patients do have to be really, ECOG 0-1. So we'll see with this initial trial, kind of the logistics, how they are different. But I think it's really cutting edge and interesting stuff that's going to be happening in the next few months.
So do you worry both with CS1 and CD38 directed CARs that those targets are not quite as narrowly expressed as BCMA?
For sure.
And you might get into some trouble if you do that.
And that's,
so
you read my mind. I was going to make that comment.
Yeah.
I was just curious, what starting cell dose are you going to use for your
patients?
So
we're actually lower because it's an allo, so it's 3 times 10 to the 6th, and then there's a -1/2 to the 5th. And I think, yes, CS1 is on, NK cells, it's on regulatory T cells, it's on T cells, so that's why we knock out CS1 so there's not fratricide. So the question is, are you gonna have even more lymphodepletion now, right? So all these CAR Ts have been great, but one of the big issues besides CRS and neurotox that we have learned to take care of, and those are actually pretty reasonable, but I think the neutropenia and the thrombocytopenia, in some patients it's more than 6 months. So you have to make sure their PCP prophylaxis, you have to make sure their levaquin and other things, bacterial, fungal, when their CD4 counts are still low. So for a CS1, are we going to have more lymphodepletion and then actually end up with longer thrombocytopenia, neutropenia? So those are, very relevant questions.
And I think the other big question, just more in the CAR T space, right, is the cytopenias immune mediated or conditioned? And I think most of us believe it's probably
immune mediated rather than
Exactly.
conditioning.
Yeah.
Yep, I agree.
So it's interesting, and just again to, I won't say play devil's advocate, but if you look at another way to get to BCMA, the GSK ADC, median PFS was 12 months, right? So yes, there's ocular toxicity, but you don't have CRS, you don't have prolonged cytopenias, at least in that small experience. And I think we need a larger data set to really know. But PFS for PFS, they were similar.
But
right?
my comment would be, how long does it take you to get an ophthalmologist to see your patient?
Quicker than it takes to make CAR T cells.
Yeah, I mean, so the argument can be made that you were actually getting, even within those relapsed refractory myeloma patients who've seen multiple lines of treatments, it's really the good ones who are getting the CAR Ts, because those patients who cannot get bridging therapy or are blowing through bridging therapy, they're not the ones who are being screened and enrolled on those trials.
Right. And I think the 60% response rate, once again, continuous therapy versus an 85% response rate for BB2121, one-time shot, right? And I get it. Yes, that first month is definitely a lot harder if you get the neutropenia. But I do think that if you're someone that's otherwise healthy, you're working, I would pick the CAR T then, but not everyone can get it.
But I mean, the GSK, only about 40%, if I'm wrong, got prior dara too, right?
Right.
So it's not as fair a comparison either.